So we're adult learners. I've learned a long time ago we need to put our take-home points up front so that way you know what to pay attention to and when to fall asleep, okay? All right, just briefly, so just to put us in a framework of discussing these important topics, let's just go through a quick case. 47-year-old male came in with diabetes, has diabetes, came in with 4 days of fever, progressive shortness of breath. He was hypoxic in the emergency department, tachycardic, a little bit hypotensive and febrile. You can see their admission labs there. They were COVID-19 positive. Creatinine was already 1.7. We don't have any pre-morbid or pre-illness creatinine, so we don't know if this is CKD or if this is already community-acquired acute kidney injury. CT chest showed multifocal infiltrates and consolidations. He was intubated emergently. Overnight in the ICU, he received a fair amount of 0.9% sodium chloride, which is a whole different topic, required deep sedation, was started on norepinephrine, and only made a couple of cc's of urine over the course of the day. And despite the volume expansion, his creatinine was up to 2.8 already on the next day. You can see he's a little bit acidemic with a mixed respiratory metabolic acidosis. He's on a fair amount of oxygen and PEEP. So, does this patient have acute kidney injury, yes or no? Yes, okay? Does the acute kidney injury impact his outcomes? Probably. Yes. Does he need dialysis right now? That's the question, right? So that's what we're going to talk about. So let's go back to the KDIGO guidelines that Dr. Goldstein talked about before. What do they say? So KDIGO says that we should start dialysis for life-threatening changes in fluid, electrolyte, acid base. I think that is a no-brainer. It's not graded, but it is a no-brainer a little bit. But they go on to say that we need to consider the broader clinical context, the presence of conditions that may or may not be modified by dialysis, and the trends in laboratory tests rather than single measurements here or there to make decisions. Okay? Again, a nice touchy-feely statement, but doesn't really help us at the moment of trying to decide what we're going to do. And when we're seeing our patients, if we're seeing them where the arrow is and creatinine is increasing and we've had a time from the insult, we don't really know what curve this patient's going to be on. And that's part of the problem, right? If they're on that bottom curve who is destined to just start getting better, would you have wanted to put them on dialysis? I mean, you may be introducing harm with no benefit for that patient. And that's really the hard part, is that we haven't really done a great job yet of being able to clearly exclude the patients that are destined to get better from trials and only enroll people who are destined to need dialysis. So these are some of the challenges you'll see in some of the data that we're going to go. What are the disadvantages of starting dialysis? Well, you have infectious or mechanical complications of the catheters. Who here constantly hears about CLABSIs all the time, right? We have a disproportionately high number of our patients who have CLABSIs happen to have a dialysis catheter. Now, they like to blame the dialysis catheter. I tell them that most of them also have other central lines because they're critically ill. So we don't know that it was a dialysis catheter, but there are risks associated with them. Biocompatibility of membranes. We do have membrane reactions still. You get bleeding issues, anticoagulation issues, transfusions, drug losses, nutrient losses, cost. All of these are important considerations. The most important are probably the ones I've highlighted in blue here. Let me move on to the next slide. I don't know why it's not going forward. Okay, so what are the theoretical advantages, though, to start early? We can get on top of things before they get out of control. That's largely the idea, right? That if we start early, maybe we don't get to the point that this patient has blisters because they're so fluid overloaded, right? Or I've put lots of patients on ECMO because no one paid attention to how much fluid they got in the last 3 days. And that's sort of an embarrassing reason to put somebody on ECMO. Oh, we just, drowned them. So let's start ECMO. So if we stay on top of these things, theoretically, potentially, we avoid some of those challenges. And it's really important to remember, this was a really important study that was about a decade old now, out of the Harvard system, that looked at a database of 15 or 20,000 patients. And what they showed was that the deaths from AKI are really not from the AKI itself. It's from the complications associated with AKI. If you have AKI, you can't control your acid base well, you can't control your potassium, and you can't control your fluid. And when you control for those problems, if you see in the graph from model one plus hyperkalemia, you go down that list, as you control for those issues, there really isn't a huge increased risk of death from stage 3 AKI compared to no AKI. It's those issues that are driving the deaths, okay? And that dialysis improved survival in patients that had those problems in this cohort, okay? And I'm not going to have time to get into all of the amazing work that the pediatricians have done looking at the dangers of fluid overload. They have really led the charge from Stu's group and others in the pediatric world about how bad fluid overload is. I'm going to highlight 2 additional studies in the adult literature. I could do a whole hour just on fluid management and fluid overload and why it's bad. But let me just bring it into specifically in acute kidney injury. We talked about before that fluid overload is one of the things in the previous slide that's driving deaths. We have 2 really important studies that look specifically in the AKI patient population. And if you look here, this one's from the PICARD database, which is a multi-center study in the United States. If they define fluid overload as a greater than 10% increase in weight from baseline. So if you were 70 kilos and now you're 78 kilos, you've met that category, okay? You don't gain muscle mass in the ICU, okay? You sometimes gain external fixators, but you don't gain muscle mass. So if you met that criteria, at the time that dialysis was started, you were 2 times more likely to die in this cohort. So waiting and starting after they became fluid overloaded was doubled their risk of death compared to maybe starting the patients a little bit earlier, okay? And there was a dose-response relationship here. The more fluid overloaded you were at peak, regardless of whether you were dialyzed or non-dialyzed, was clearly linearly related to your outcomes in AKI. And in fact, losing weight was actually the best because you probably were not only not gaining fluid during the hospitalization, you may have, which is a little paradoxical because you're also losing potentially muscle if you're losing as well. The percentage of fluid overload was also important. So the more fluid overloaded you were, and the more days you spent fluid overloaded, the more likely you were to die. So this suggests that if we are fluid overloaded, we need to work to become not fluid overloaded. Okay? I think that goes without saying, but the Europeans in another study in adults showed exactly the same thing. If you were fluid overloaded, you were much more likely to die. If you were fluid overloaded, time of dialysis initiation, and again, that there was a linear relationship between the amount of fluid that you had accumulated and the risk of death. Okay? And I'm not going to have time for this, but if you look at advanced studies on these, it's not just that the more sick patients get more fluid. That's the complaint that I hear a lot, but if we had time in another forum, I could show you lots of studies that show that it's not just that the sicker patients are getting more fluid, that there's a lot of studies that show that the less sick patients actually get the most fluid, and they're still more likely to die than the more sick patients that don't get as much fluid. Okay? All right. So if we go back to this case for a second, I asked you the question of whether or not we should start dialysis. They got a lot of fluid, their vent settings are high, they're probably involving ARDS, and the kidney's function isn't great. Okay? So we have a problem that we have to solve. We have to identify the problem, develop alternatives, select the best alternative, may or may not have a perfect answer, implement that, and then look to see if our solution works. So in our patient, we have AKI, oliguria, volume overload, respiratory failure, acidemia, or critically ill. Our options are to start or to wait, okay? So where do we stand on this? Where can we move forward? So let's spend the next 15-ish minutes, 10 minutes, looking at what the data shows on some of these timing questions, okay? I'm gonna go through several trials and sum all that up at the end. So don't feel like you need to remember the details of the trials. I'll summarize them. Just try to remember at least a little bit of the names of some of the prospective ones that we go through. All right, so the first thing was there was a meta-analysis back in 2012 that looked at a lot of studies, about 3,000 patients, albeit most of them were prospective or retrospective trials and only a couple randomized controlled trials at that time, that suggested that potentially starting dialysis earlier was better. Okay, so that led to a lot of randomized controlled trials. And we've actually done, I would say, really amazing work in this space. Some of the trials I'm going to show you are the largest trials that have ever been done in the nephrology world. So this is really impressive, and kudos to the researchers that did all this. So the first trial is the AKIKI trial. It's a multi-center trial in France. They randomized adults who were on the mechanical ventilator or pressors. Most importantly here, they had KDIGO stage 3. So they had already had their creatinine increased to 300%. It's normal, okay, before they could even be considered to get into the trial. They were randomized to early, which meant starting dialysis basically right away, or delayed dialysis, which meant either waiting until they were not better for 72 hours, okay, or meeting one of these criteria, okay? And they showed no difference with an accelerated or an earlier approach. And importantly, in the early approach, everybody got dialysis because no one had time to recover if you were starting within 6 hours. But in the delayed arm, only about 50% of the patients actually ended up requiring dialysis, which meant the other 50, in waiting that extra time, largely got better, or some of them died. Okay? The ELAINE trial was a single-center trial in Germany. 8 adults again. They had to have elevated biomarker of NGAL, which sort of suggests they have ATN. They needed to have one of these other factors, severe sepsis, on catecholamines, fluid overload, or a high SOFA score. But importantly, they were KDIGO stage 2 patients, okay? Which means that their creatinine had only doubled, basically, instead of tripled at the time of enrollment. So these people were being considered at an earlier stage, okay? And again, they were early, very early dialysis, or a delayed strategy in which they had to wait to reach stage 3, or have one of these emergency criteria, okay? And they randomized 250 patients, mostly post-surgical patients, and, and they showed that, again, in this trial, almost everybody ended up getting dialysis. So they didn't have this issue where 50% of the patients got better, okay? And you can see there was quite a difference in the time from when they were KDIGO stage 2 to starting dialysis. They were either KDIGO stage 2 and sort of immediately got on dialysis, or they waited 2 days. And they showed that there was a separation here between outcomes and survivals, that being in the early dialysis group favored for a better mortality. And that was across all sorts of different metrics like ICU stay, hospital stay, duration of mechanical ventilation, all important things that we care about, right? Even if it's not necessarily survival, that's better, which is important. All these other factors were potentially better as well. All right. Another trial, the IDEAL ICU trial, again, a multi-center trial in France. Again, KDIGO stage 3, so this is the waiting already. They've already reached the 3 criteria. They had to be in septic shock early in the hospital course, again, early versus delayed. You can see the breakdown here. Everyone has these emergency criteria that sort of, you get dialysis because we don't want you to die from hyperkalemia situation. This trial randomized enrolled about 500 patients, but was stopped early, not because they were killing people, but because they were not going to be able to find a statistical significance. So they said continuing the trial was futile, okay? They weren't going to ever reach anything. So that just goes to show you that there was no difference in outcome between these 2 groups, okay? So very similar to the AKIKI trial. And the last, or the 2 more trials to just very briefly touch, this is the START-AKI trial, which many people point to as a definitive trial. This is the largest trial that's really been done in the nephrology space almost ever. It's 18-year-olds in the ICU, KDIGO stage 2 or 3. They had some exclusion criteria, so people that seemed like they were going to need dialysis basically immediately because their K was high and they couldn't really wait. They wanted to exclude those patients. People who family and the team wasn't really committed with the idea of potentially doing dialysis were excluded as well. They got accelerated or standard, again, persistent or these other indications. So all the trials are largely designed the same, except for sort of like what stage of AKI you get in. This study enrolled 3,000 patients across about 100 to 150 different centers around the world on basically almost every continent of the world. And they showed no difference in outcomes from a timing perspective, okay? And then lastly is the Akiki 2 trial, which again, they said, well, if accelerated isn't better than standard, what about standard versus a more delayed approach? So they said, let's use the delayed arm from the original Akiki, and we'll randomize you at that point, or a more delayed or postponed approach where you only got dialysis if you met one of these indications, okay? And I'll get to that trial in a second, so hang tight. All right, so when we have our questions about for dialysis or against dialysis, we have to weigh these different factors that are important considerations that we need to think about, okay? So I want to point out now, I talked to you about the headline results of these Akiki, Ideal ICU, Elaine, START AKI, and Akiki 2. But I want to point out some notable findings that are important and are reason to maybe have some pause. If you look at the Akiki trial, which was early versus late, that showed no difference, and 50% of the patients never needed dialysis. If you split out now the delayed arm and you look at the survival of the patients who never needed dialysis versus the survival of the patients who did ultimately require dialysis in that arm, you can see a stark difference there. And the delayed arm renal replacement therapy patients had a worse survival than the people that were in the early arm. So the two arms may have been overlapping because the recovery people, which are obviously, if you're spontaneously recovering, probably have a better outcome, right, are sort of muddying the water potentially. And that was a very similar thing shown in the Ideal ICU trial, that again, if you break these down and you look at the patients who never got dialysis versus the patients who did get dialysis, those who never got dialysis did much, much better overall because they had spontaneous recovery. And in the group that did end up needing dialysis in the delayed arm, that met those emergency criteria, not just that they waited 72 hours, but they met those emergency criteria, had a pretty strikingly high mean mortality rate, okay? These are all subgroup analyses, so these are not primary, we can't read too much into this, but it's important, I think. There's a safety signal here that is concerning, okay? And in the Akiki 2 trial, which was delayed versus more delayed, okay, there was clearly a statistically significant increased risk of death of being in the more delayed group. Finally, in the START AKI trial, which I showed you as this amazing trial that they did incredible good work. I have nothing but praise for the people that did this trial. There is also a little bit of a safety signal that we need to be careful about. So again, in this trial, if you look here, the green arm was the accelerated arm. Everybody got dialysis, okay? In the red solid arm, that's the standard group. Only about 50% of patients, 60% of patients in that standard arm ended up getting dialysis, okay? Now, go down to these dash lines. So on the green dash line on the bottom, these are the people in the accelerated arm. No one died before dialysis was initiated. Okay? In the standard arm with these dashed line, you can see that there is not an inconsequential number of patients that died here before dialysis was initiated. And what we don't know from this trial is, did they die because the families and the multidisciplinary teams decided that dialysis wasn't appropriate for that patient and they withdrew care? Or did they die from one of these complications related to dialysis that I talked about before? And I think that if we know that someone is potentially going to die from these complications, we can maybe prevent that death by starting dialysis a little bit earlier. This, again, suggests that there may be a safety signal here. So we have to be a little bit careful during all of this. So what's the summary? There's no difference, okay? But again, only 50% of the patients with delayed arm got dialysis. In the Elaine trial, there was potentially an improvement. And in the Akiki 2 trial, more delayed appeared to be harmful. So we're left sort of thinking, if we try to conceptualize this overall, and we have this question of when to start dialysis, and we have time along this axis, we can either do preemptive dialysis, urgent dialysis, or emergent dialysis, thank you, or emergent dialysis, all right, which is like, K is 7. As you move along this, you're going to accumulate complications, which means that the ability of dialysis to potentially put all the genie back in the bottle is getting harder and harder and harder. Does that make sense? And the benefits that you may be getting from dialysis are going down. And potentially the harm from starting early, though, is also potentially going down as you go. So what might be too early for some patients might be too late for other patients. And so we're not going to be able to hang here on a clinical trial that's going to tell you when is the best time to start this. You're going to have to sort of individualize this based on how your patient is doing. Just know that starting everybody early is probably not helpful on the grand scheme of things. And being somebody who doesn't want to do dialysis because dialysis is defeat of the nephrologist, which sometimes I've run into, okay, that's also not okay. That we need to sort of have a Goldilocks moment here. We may be able to use furosemide stress tests to help us with this. There's a number of trials, albeit them small, that have consistently shown that whether you are a responder or a non-responder to furosemide is a good predictor of whether or not you'll end up needing dialysis. So if you have this patient, I don't know if they're going to get better. They've got stage 2, stage 3 AKI. I'm on the fence about dialysis. You give them a dose of Lasix. You may not be ready to make them net negative. You're just trying to test whether their kidneys are responding. If they respond, that might be the patient you can maybe wait on. As opposed to the person that you're on the fence about who isn't responding, that might be somebody that you shouldn't wait on. And Dr. Goldstein alluded to this before, but the ADKI group, I'm sorry that my reference got messed up there, so I apologize. The ADKI group showed this very nice concept that we need to weigh what is the demands on the kidney versus the kidney's capacity. And when that gap separates, that demand versus supply, demand versus capacity gets really big, something has to fill that gap. And if the patient's kidneys can't do that, a machine might be necessary. Okay? So if we go through this clinical decision-making area, and we say, okay, we're going to start dialysis, now what? I'm not sure on that case whether I would. I probably would have given furosemide stress tests to that patient, but let's just hypothetically say we're starting dialysis. Okay, so a fan favorite of mine, Tom Brady, would always say, do your job. He would actually say, do your blank job, but do your job, right? So if we are going to start dialysis, we need to make sure that we are doing our job well. Because a machine that's just sitting there spinning is not necessarily going to help the patient, okay? So I like to talk to people about the 6 steps for successful dialysis, okay? The first is we need to have close collaboration. I'm going to talk about that in a few minutes, but we need to have close collaboration with all these different service lines. You can put I don't have the patient in here because I'm in the ICU and many of my patients aren't capable of participating in decision-making at this collaborative point, but they should be in there as well. We need to establish a daily goal. Okay, this is so important. What are we trying to use the machine to do today? All right, and we need to have daily discussions about what this goal is, because we will collectively as a team be better able to achieve the goal if we know what the goal is. If the doctor has said, I want to do this, but hasn't communicated that well to the nurses or the pharmacists, then good luck. It's not going to happen the next day. We need to have clear communication, establish that goal. We need to keep our machines running, okay? We need to have a great vascular access, and we need to have anticoagulation. We're going to hear more about that. And then the final 3 steps are we need to address medication dosing, we need to ensure appropriate nutrition support, and we need to avoid complications associated with dialysis. So the reason why I like to talk about these 6 steps, the first 3 steps, we do this every day. This is how we maximize the chance that our machine provides a benefit to our patient. Does that make sense? We should not be naive enough to think that these machines are benign, Just like ventilators, they can introduce a lot of harms to our patients, and that's what our last three things are, is trying to minimize the harm associated with these patients. So we need to maximize the benefit and minimize the harm, okay? So let's go through a couple of these very quickly. Dialysis is a team sport. We got to work together. No one works in isolation on this, okay? Everyone has to communicate. Dialysis is a spectrum. You've already heard this from Dr. Goldstein. I like to differentiate between conventional outpatient hemodialysis and tailored optimized hemodialysis in the hospital. Most patients in the ICU are not going to tolerate outpatient dialysis settings, so don't prescribe it that way. And then what about PD? So we need to individualize our plans based on our goal. What is the goal? If the goal is correction of ethylene glycol ingestion, I can't do that very quickly with CRRT. So the patient may be very unstable, but I need to do hemo to get that ethylene glycol out. That makes sense? Okay, even if you turn up the dials all the way on a minute-by-minute basis, hemo will blow away CRRT for removal of ethylene glycol, okay, or methanol, or something else, okay? So the goal of what we are using the machine for today needs to drive our therapy, and we know that CRRT is better for some things, and intermittent hemo or PERT are better for other things. So if our goal today is fluid removal and cardiovascular stability, I need to be thinking about CRRT. If my goal is to correct the K of 10, I need to be thinking intermittent hemodialysis. Okay? Make sense? Okay. These are not, Dr. Goldstein, this is the 6th time they're hearing it, I think. These are not competing modalities. These are collaborating modalities. These are modalities that are working together to achieve the goals that we want, and our patients will move between these potentially, depending on what the goal of therapy is. Now, I want to turn to this point about daily goals, okay? I highlight this study because they were very vulnerable in this study, and they published information that they should be credited for publishing. Dr. Osterman and the people that wrote this article, they work at a very busy, extremely good CRRT center in the UK in London. They publish a lot of stuff about dialysis. They went back and they looked at what percentage of time, what percentage of days that the people are on CRRT are the teams actually establishing a daily fluid balance goal, okay? And they were shocked to find that they were not doing a good job with that. And I give them credit for admitting that, okay? Only about 40% of the time was the team talking about this every day. And in a huge percentage, there was like in 55% of the time, it was somewhere between 50 and 100%, okay? So a lot of patients, the teams were not discussing this every day. So they weren't really establishing the goal. They were doing CRRT, but they weren't really discussing it. Now, there was a little bit of relation to severity of illness here. So the patients that were really sick with very high SOFA scores, people understandably may not have been caring about fluid removal. So maybe that's why they didn't talk about it on that far end of the graph. But there's really no difference between an 11.7 and a 12.4 SOFA score clinically, right? They should have been discussing fluid and what they wanted to do. And I would venture to say that this is true in a lot of our hospitals, that we don't talk about what are we trying to do today. Do we ever say we're not talking about what we're going to do with the ventilator or what we're going to do with the pressors? No, we always say what we're going to talk about. But because kidney is like 17th on the list of things on the organ systems to cover, people are fatigued by the time they get to that, and they just sort of gloss it all over, and they're like DVT prophylaxis, dialysis, whatever. Okay, PPI, you know, food, okay? All right. What about feeding failures during dialysis? So in a pediatric patient population where food is important, they looked at how many times were they achieving meeting the goals of what they wanted to do, and they showed that if you look on the feeding modality, 32 were getting just PN, 56% were getting parenteral nutrition and enteral nutrition, but nobody was meeting feeding goals, okay? So we have to recognize that we need to make sure that we are doing our job. if we put the patient on dialysis and we don't feed them, they will look emaciated after a couple of weeks. If they become emaciated, will they survive? Probably not. Okay? All right. So let's go back into this, just highlighting these other areas. We're going to talk a lot about some of these other stuff in a few minutes with vascular access, but these are the things that lead to death in our patients on AKI, and these are the things that we need to do. We need to use CRRT to avoid intradialytic hypotension. We need to remove fluid, de-resuscitate our patients, and ensure appropriate nutrition support and drug dosing. Okay? So I don't have time to go into all of those specifics, but I wanted to at least give you the highlights of what you needed to think about from a protein and micronutrient deficiency. Okay. All right, let's finally talk about fluid removal with dialysis. I put in some pictures of Atlanta so that you can see that we are a nice city and you should come to Atlanta and visit. This is Piedmont Park, which is our central park in Atlanta. It's very nice. Okay, so modality matters. I'm not gonna get into this, but we can't remove fluid effectively with intermittent hemodialysis. If you're fluid overloaded in the ICU and you're tenuous, I can't get you back to euvolemia. That's been shown in many studies, okay? So let's move forward from there and just say if they're very fluid overloaded, we need to use CRRT. So the question is, how do we do fluid balance and what is the data between the speed of fluid removal, okay? All right, you've got sort of two options here. You've got this fixed patient fluid removal idea, or the idea that Dr. Goldstein talked about, which is the dynamic patient fluid removal strategies. So on the fixed area, the CRRT orders specify a fixed patient fluid removal or a PFR rate, or on the Baxter machine it's called patient fluid removal, ultrafiltration rate. The machine is set to that and is not adjusted hourly unless the orders change, okay? This relies on the ordering provider to determine the desired fluid balance, how much they're gonna be potentially getting in that day, and calculate an hourly PFR to achieve the desired fluid balance for the next 24 hours. Essentially, you have to do this. What's my estimated daily intake? I need to add my fluid removal on top of that, divide that by 24, and that's what we need to do. Would you guess that we are particularly accurate at 7 o'clock in the morning or 9 o'clock in the morning, deciding how much fluid they're getting at 9 o'clock at night? Not particularly good. So we use this dynamic approach where the orders specify a desired fluid balance goal for that hour, okay? So we say we want the patient to be net even or net zero or net negative 50 or 100, or we may put a range in there so that we don't have to change the orders every 5 seconds, okay? The bedside nurse will adjust the PFR on the CRRT based on math that she or he will do at the bedside based on how much they're giving every hour, okay? So I'm giving 200 cc's of vancomycin. We need to be net negative this hour. I've got these number of drips. I'm going to set the machine for this. That make sense? Okay. You'd be surprised. This is a very hard concept to teach. And for those of you that may be nursing educators, if you come up with a really good way to get all the nurses to understand how to do this math, can you please share it with me? Because we struggle with this sometimes. I was not good at math, but I've at least gotten my handle around this over time. So if you can come up with good educational tools, please share them with me. Okay, now what about the speed of fluid removal? There have been 5 trials published on this topic about how quickly we can take away fluid. I'm going to zero in on these for my last bit of time because I want to point out some things to you that, with all due respects to Dr. Naira, I think has been we have been hampered here by the titles of these trials, okay? If you look at all these trials, it says net ultrafiltration intensity, association of net ultrafiltration rate, association of net ultrafiltration rate, blah, blah, blah. You see that? They're using this term net ultrafiltration. Let's zoom in on these, okay? Take these first 2 trials. Same group. These are how they were designed. They were retrospective cohort trials of the Renal trial, which was an Australia trial about high dose versus low dose dialysis. You don't need to worry about that. Primary endpoints were time to independence in one study of dialysis and survival in the other study. The variable was the UF net rate, okay? And the UF net rate was defined as the cumulative amount of fluid that was removed divided by essentially the number of hours they were on dialysis, okay? So, as you will see in the other trials, there's an important part of this that's not in here. which is what is the intake of the patient. So the idea that we're calling this net ultrafiltration in all of these trials is the wrong terminology. And for those people that are not nerdy nephrologists like me, that are just reading the title and the abstract, are getting the wrong impression of what these trials have shown. And that's a problem. Okay? So terminology and words matter. All right. So in these two trials, they showed that having more fluid removed was potentially harmful for patients in those first two trials. Okay? Now, if you look into some details here, I highlighted some specific areas. My pointer isn't working that well, so I'm sorry. But if you look here, the group that had not a lot of fluid removed didn't actually achieve a net negative fluid balance. That's an important thing. So the people on the further right that had more fluid removed had actually achieved a net negative fluid balance. What was the other thing I wanted to point out? Oh, you can see that the cumulative fluid balance, excluding the amount that was taken out, was quite positive in the groups that were on the taking a lot of fluid off. So the taking a lot of fluid arm were all fluid overloaded, and they were trying to get them not to be fluid overloaded. Okay? Come back to this in a minute. The same group did another trial using a different retrospective database, and again looked at patients who were fluid overloaded at time of dialysis initiation, divided them into these categories of patients, and this group in this study, with the same researchers but using a different cohort of patients, showed that more fluid removal was better. Okay? All right. The last two studies just quickly show, again, they're looking at net UF, but again, there's no net part of this. There's no actual intake calculation. It's all just looking at how much the machine took away, showed a sort of U-shaped curve that too much was bad, too little was bad. Okay? And then this trial, again, looked at this net UF. I don't know what happened to these fonts here, but they showed that taking off more fluid was, again, better. Okay? So, in summary, we have 5 trials that use different studies and different metrics, but none of them looked at actually how much fluid the patient was getting in. Some of them showed that more fluid removal was bad. Some of them showed more fluid removal was good. Okay? So, are you confused? Okay? All right. I think there's a lot of problems with these studies, and I'm hoping that Javier's study is going to finish this. Location bias. So the trials that showed that more fluid removal was bad were done from patients that were enrolled in Australia and New Zealand. They tend to be a very fluid conservative area of the world in critical care, and they don't generally achieve a lot of fluid overload in those patients. The second thing is, and the studies that show that more was better were done in the US, where we tend to drown people. CRRT net UF is a totally incorrect term. I've already talked about that. Okay, these trials say nothing about what the net fluid balance is for the patient, and that is way more clinically relevant. Okay, there's also a lot of population bias, in my opinion. If Dr. Goldstein I put him on dialysis now after his coffee, and he's not fluid overloaded, would I turn all the dials up all the way to remove a lot of fluid? No. Our decisions about how we turn the dial is based on how much fluid we think he needs to remove. Right? And when we don't know anything about what the intake is or what the patient's fluid balance is, if you are turning up that dial, then theoretically they're either getting a shit ton in, getting a lot in, okay, which means that they're usually thicker if they're getting a lot in, or they're already fluid overloaded, and I already told you that fluid overload kills the patients. Okay? So the patients that were getting a lot of fluid off were probably patients that needed a lot of fluid off, and they were probably already had a higher risk of death because of that. So the speed of the fluid removal may not necessarily be the issue. This study that I showed you that I already showed you this, or they didn't do a particularly great job establishing the fluid balance goals. They did show that there was a greater fluid reduction during CRRT was associated with higher survival, and that the number of days was an established fluid balance goal correlates with the likelihood of achieving your goal. Okay? So what do we do at Emory? We remember that fluid overload prevents organ and patient recovery. In the maintenance phase of illness, we target at least a net even to negative fluid balance. We start evacuation and deresuscitation and monitor the tolerance very closely for how the patients are doing. And if they're tolerating that fluid removal, we will increase the speed of fluid removal and tolerate some low-dose vasopressors, because it's not a race to liberate from vasopressors, it's a race to liberate from the ventilator and sedation. Okay? So in conclusion and summary, AKI is common, and we're unable to tell you the exact timing when to start. You need to individualize the decisions to start, maximize the benefit, and minimize the harm. Think of your 6-step program. Evacuate and remove fluid as the patient recovers, and speed of fluid removal should be guided by the patient's tolerance. And please, 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 these patients need to follow with an outpatient nephrologist. We are not good at this. If they end up on dialysis in the ICU, they need to see a nephrologist. Okay?